Hello, I'm Jennifer Brown, Director of the CLL Center and Institute Physician at Dana-Farber Cancer Institute in Boston, and the Worthington and Margaret Collette Professor of Medicine in the field of hematologic oncology at Harvard Medical School. And today I'll be discussing novel agents and combination strategies in CLL. The first trial that I wanted to highlight is AMPLIFY. AMPLIFY was a phase 3 multicenter international trial which compared acalabrutinib venetoclax, obinutuzumab, and FCR or BR, investigator choice, in terms of a primary endpoint of progression-free survival. So the primary endpoint was reported at ASH in 2024 and has recently been published in the New England Journal of Medicine. And that's shown in the left curve, where you can see that the three-drug combination of AVO resulted in an estimated 3-year progression-free survival of 83%. The two-drug combination of AV resulted in a 3-year progression-free survival of 76%. And the chemoimmunotherapy arm had a 3-year progression-free survival of 66%. So this was significant for the comparison of AV to chemoimmunotherapy and for AVO to chemoimmunotherapy. There's no planned comparison between the AV and AVO arms themselves. I would draw your attention also to the data on the right, which is a planned analysis looking at progression-free survival by IGHV status. And what's particularly interesting is that we see that even with the higher risk unmutated IGHV, the patients on the AVO arm have a very similar progression-free survival to the overall group at 83%. Typically, we would expect that the progression-free survival for the unmutated patients would be worse than those with the mutated IGVH, but it's actually quite similar. And then in the AV arm, we do see some decrease to 69% for unmutated IGVH compared to the overall cohort, and then certainly also with the chemoimmunotherapy. The median PFS was not reached for AV or AVO and was about 4 years for chemoimmunotherapy. In terms of rates of undetectable MRD in evaluable patients, that was about 45% for AV, 95% for AVO, and 73% for chemoimmunotherapy. That was measured at the end of treatment time point. The end of treatment time point for AV and AVO is about 14 months. Most of that's the combination of acalabrutinib and venetoclax. Obinutuzumab is given between months 2 and 7 in the arm that got obinutuzumab. And then for chemoimmunotherapy, it's obviously a couple months after the 6-month mark. So what about the results? Well, this is the first potential registration trial in the United States for BTK BCL2 combination, the first such registration trial for a second-generation BTK inhibitor. I'm sure people are aware that ibrutinib venetoclax has been studied in multiple trials, including the GLOW trial, which was a registration trial. And that regimen has received approval in Europe, but did not receive approval in the United States due to safety concerns, particularly cardiac events with ibrutinib in the older patient population. So in the United States, we haven't yet had a combination of BTK and BCL2, and hopefully we will soon hear about an FDA approval for this. The acalabrutinib venetoclax arm was really very safe and very easy. The rate of adverse events in terms of neutropenia, which was the most common adverse event, was really rather low, and infections grade 3 or higher were only 12%, which is lower than almost all of our frontline therapies. So I view this as potentially applicable to most any CLL patient, well tolerated and easy. The AVO 3-drug regimen was very effective. As we discussed, it equalized outcome in the unmutated and mutated IGVH patients at 3 years. This is at a cost of somewhat more neutropenia and more infections, and so that's something to bear in mind. Particularly in this trial at the height of the pandemic, there were more deaths on AVO compared to AV or chemoimmunotherapy due to COVID. I think that's probably a unique feature of what happened during the pandemic, though, and that would not happen now. And so the AVO arm is particularly good for higher risk unmutated patients, perhaps those with bulky lymphadenopathy who are young and able to handle it. Now, in parallel, my colleague Dr. Davids presented a 3-drug acalabrutinib venetoclax obinutuzumab regimen for patients with high-risk 17p deleted disease. And in this study, the regimen went for 25 months, but patients with undetectable MRD could stop after 15 months. And we now have 4-year progression-free survival for this cohort. And that's 96% in the patients without P53 aberration and 70% in the patients with, despite pretty comparable rates of undetectable MRD in the patients with and without P53. This PFS, I think, is still reasonably good for these P53 aberrant patients. How it compares to patients on continuous BTK inhibitor is obviously not clear since we don't have a head-to-head trial. And we also don't know how readily people can be retreated after this time-limited regimen. So this is a longer MRD-guided AVA regimen that was studied in patients enriched for 17p deleted disease, where it was highly effective in inducing undetectable MRD remission with a bone marrow undetectable MRD rate of about 85%. The durability, as we just discussed, is somewhat reduced compared to the 17p wild-type population, but nonetheless, it does look better compared to venetoclax or obinutuzumab, where we see that the 17p deleted patients have a median PFS of about 4 years. There is an ongoing head-to-head trial in the German CLL study group comparing a 3-drug regimen of acala, ven, oben to ven, oben in patients with high-risk 17p deleted disease. The Germans have also studied acalabrutinib, venetoclax, and obinutuzumab in relapsed CLL. And this is an interesting study because it was really rather heterogeneous in terms of the patient population and their prior therapy, but most of them had high-risk biomarkers, 76% unmutated IGVH, 32% with P53 aberration. About 40% had prior BTK inhibitor or venetoclax. They had optional debulking with bendamustine, followed by initiation with the obinutuzumab first, whereas the other regimens we've been discussing all start the BTK inhibitor first. In this one, obinutuzumab started first, then acalabrutinib, then venetoclax. And there's MRD-guided maintenance phase after the initial induction of 8 months. And so the overall rates of undetectable MRD were actually quite high, 75% post-induction, and the best undetectable MRD was 93%. And the 3-year progression-free survival is 89%. This is really fairly impressive for the 3-drug regimen in the relapsed heterogeneous cohort. And I think it does underscore the potential of using this in later lines. On the right, you can see at the top the time to undetectable MRD and MRD dynamics. And in the green, the patients who achieve undetectable MRD do so at widely variable times, which is exactly what we observe clinically. Whereas there are some in red who don't achieve undetectable MRD. And we see that in most of these studies that a certain percentage, 10 to 20% of patients, no matter how long you keep treating them, will not get to undetectable MRD. And we don't understand the biology of that as yet. So again, this is a heterogeneous group of heavily pretreated patients where I think the regimen is surprisingly effective with a 3-year progression-free survival of 85%. But this issue of using MRD guidance, and then some patients may not get to undetectable MRD, what do we do about that? Do they stay on 2 drugs indefinitely? I think that maybe that's not the best idea because then when they progress, they'll be resistant. But then how long do we continue before we stop? And these are issues that are not readily studied in most clinical trials or readily studied comparatively. So it's something that we're going to have to sort of start to assemble a body of literature on from the many variable experiences. I think that the efficacy of the regimen does underscore the importance of trying to avoid the development of resistance to our key mechanisms, BTK and BCL2. Although we do know that combinations can still work in patients individually resistant to either drug, but probably won't work for as long. There's interest, of course, in combining zanubrutinib with venetoclax, and we've heard updated data from Sequoia RMD. Sequoia, of course, is the registration trial frontline for zanubrutinib, and RMD is a combination of zanubrutinib and venetoclax, which starts with a 3-month lead-in of zanubrutinib and then has combination therapy for 12 to 24 cycles dependent on undetectable MRD early stopping rules, and then zanubrutinib monotherapy until disease progression or toxicity. Now, this study has very strict discontinuation criteria where patients have to have 2 bone marrow biopsies to confirm an additional to peripheral blood. And so not all patients have always had all the bone marrow biopsies. And most patients have therefore continuing on treatment even beyond cycle 28 when they continue zanubrutinib until they meet the strict stopping criteria. Now you'll notice on the right also that the rate at which undetectable MRD shown in the light and dark green accrues is taking a little bit longer. Like we only start to see a good chunk of the bar out at about week 60. And as we get to week 108, 132 there, we're seeing more than 50% of the patients with undetectable MRD. Now the patient population that's been reported so far in this study as patients with 17p deletion. And that may be why there's a longer time to undetectable MRD. So again, relatively slow achievement of undetectable MRD, which doesn't really worry me. I think that is probably due to the 17p deletion. The very strict stopping criteria means that most patients have continued on therapy, and that does raise the question, is this really a time-limited regimen, which we were discussing a little bit before with respect to the AVO regimens. It may be, though, that with the 17p deleted patients, a longer treatment duration is preferred. But again, we don't really know that. And at the moment, there's not really any progression-free survival data. Response rates are extremely high, but we don't have progression-free survival data from this cohort yet. So that will be eagerly awaited. Now, turning our attention to a novel BCL2 inhibitor, sonrotoclax. So sonrotoclax is in development, and it has about 10-fold potency in vitro greater than venetoclax. And it also has activity against the primary BCL2 resistance mutation, G101V. So that's been studied in an omnibus phase 1 study that includes a combination cohort with zanubrutinib. So BTK BCL2 combination. And we had an update on this at ASH last year, where you can see on the left that the response rate is essentially 100% already by week 24 at both dose levels of sonrotoclax 160 and 320. And the CR rates go up and reach about 40% by week 48, which is quite reasonable. And then on the right, the rates of undetectable MRD are also quite high, 78% in the 320 milligram dose by week 24 and up to 91% by week 48. So sonrotoclax and zanubrutinib are demonstrating substantial anti-tumor activity in treatment-naive CLL. As I mentioned, sonrotoclax is more potent in vitro, yet so far there's been quite limited tumor lysis on this study. The ramp-up schedule is pretty much as complicated as venetoclax, although in some of the later studies, they are trying to simplify it to make it easier than venetoclax. This study does represent the highest undetectable MRD rates we've seen with any BTK BCL2 combination if you don't have an antibody. But it's also a selected phase 1 population at selected centers, so it needs longer follow-up and more broadly multi-center trials to see if these rates of undetectable MRD hold up. There's also been only one progression event so far, but again, follow-up is relatively short. Pirtobrutinib is a non-covalent BTK inhibitor, which was approved by the FDA about a year ago, a little over a year ago, for patients relapsed after BTK and BCL2 inhibitor. And there is a large phase 3 program in place for pirtobrutinib. And at ASH this past year, again, we heard the first results of one of the randomized trials of pirtobrutinib, which is the Bruin 321 study, comparing pirtobrutinib to investigator choice of adalimumab rituximab or bendamustine rituximab, with about 2/3 of the patients having received the adalimumab rituximab rather than the BR. Patients were either venetoclax naive or venetoclax treated, about half and half, as you can see here. And so the study met its primary endpoint of improved progression-free survival for pirtobrutinib compared to adalimumab or BR. And here we're looking at the time to next treatment or death data, where we can see that it's about 30 months for the venetoclax naive cohort and about 20 months for the venetoclax treated cohort. This is not surprising, I think, because we don't know if it's a specific effect of having venetoclax treatment beforehand or just extra line of therapy, more heavy pretreatment. So this is the first phase 3 registration trial, not only for pirtobrutinib, but also in patients who have had prior covalent BTK inhibitor treatment. And Pirtobrutinib improved progression-free survival compared to investigator choice of ADELA-R or BR. The outcomes are somewhat poor overall, underscoring, I think, the high-risk nature of this group of patients who progressed on covalent BTK inhibitor. And again, underscoring the importance of what I mentioned earlier, that the advantage of time-limited therapy is that perhaps we can maintain patient sensitivity to covalent BTK inhibitors rather than waiting for them to progress. Another interesting outcome of this study is that these are the first data with a PI3 kinase inhibitor in patients after covalent BTK inhibitor. And so we do see that allogeneic rituximab activity with about a year of clinical benefit. So that is an option that's on the market available for these patients as well. Pirtobrutinib has also been combined with venetoclax and rituximab. This was done as part of the phase 1 Bruin trial originally, 2 cohorts, pirtobrutinib venetoclax or pirtobrutinib venetoclax rituximab. And you can see on the left the waterfall plot. Essentially all patients responded, and the undetectable MRD below that looks quite good. The regimen was well tolerated. And on the right, the PFS curves look pretty good, although there are about 10 to 20% of patients who are progressing before they finish the treatment because it's a 2-year regimen. And so this is a phase 1 study. Combination was well tolerated, no issues with it. Everyone stopped after the 2 years of therapy. There's a high response rate and high rate of undetectable MRD. I already mentioned about 20% progression during the 2 years of therapy, but that does reflect the heavily pretreated nature of the population. And we need longer follow-up of the durability after patients discontinue therapy at 2 years, particularly in the patients after covalent BTK inhibitor. We don't really have data about the safety of discontinuing venetoclax in that population. And so that will be interesting to see in this study how long people do once they've come off the pirtobrutinib venetoclax. And this is the basis of another one of the pirtobrutinib phase 3 registration trials, which is fully accrued, but we have not yet seen data. That being venetoclax rituximab plus minus pirtobrutinib in the relapse setting. We also heard data from the MD Anderson at ASH combining pirtobrutinib with venetoclax and obinutuzumab in the frontline setting. And you can see here that the rates of undetectable MRD, even as early as end of cycle 7, were 93%, and we're up to 98 to 100% by the end of cycle 13. Now, this was at the price of somewhat more toxicity than we've seen with some of the other 3 drug regimens. The grade 3/4 neutropenia rate was 60%. 60% of patients required GCSF. There were 4 patients with neutropenic fever, and a lot of dose reductions. 21% reduced pirto and 31% reduced venetoclax. Suggests that there could be potentially some pharmacokinetic interaction there, that the patients are seeing a lot of drug. So this is the MD Anderson trial, very high rates of undetectable MRD, higher than we've seen even with the other 3 drug regimens, but at the price of high rates of heme tox and dose reductions. So again, like most of these single center studies, needs confirmation in a multi-center setting. And I have some hesitancy to use pirtobrutinib, the non-covalent inhibitor, before covalent BTK inhibitor, because we still have very short follow-up with pirtobrutinib, whereas with covalent BTK inhibitors, we know patients can get 8, 9, 10 years of benefit from them. And so for pirtobrutinib to be better, it has to give the full benefit of the covalent BTK plus the extra couple of years it gives in patients who progressed on covalent BTK. So that's really a pretty high bar. And so until we have more data longer term with pirtobrutinib, and until we understand a little bit better the mutation profile that might occur, that might result in resistance to the next line of therapy, I'm a little hesitant. I think part of the reason they were okay with it in this trial is that it's time limited. So hopefully there won't be the development of resistance mutations, but we don't know. Pirtobrutinib has also shown significant activity in Richter's transformation. This is the largest prospective study in Richter's transformation with 80-odd patients enrolled. You can see in the waterfall plot that the response rate looks pretty good. The durability for the whole population, though, on the right is not that great, where the median PFS is 4 months. Duration of response is about 7.4 months. So again, largest prospective trial in Richter's, overall response rate was 50%, complete responses in 13%, which is somewhat unique. So high response but short durability, which is what we so commonly see with many drugs in Richter's transformation. I think it looks like it's probably somewhat better than we've seen, for example, with acalabrutinib or zanubrutinib or ibrutinib, but the data are limited with the other drugs, so it's hard to tell. I think this does suggest that it may be a basis for combination therapies, which is certainly what we clearly need in Richter's transformation. So turning our attention to cellular therapy, we did about a year ago have the approval of Lysocell, the first CAR T cell therapy for CLL. And we had an update of the survival curves from the Transcend CLL 004 registration trial. Primary endpoint of that trial was the complete remission rate, which was 20% essentially. And so the interesting aspect of these data, if you look at the top, we have the full population who are enrolled at the selected dose level on the left. On the right, we have the selected cohort of the BTK progressor venetoclax failure subset, which was the basis for the approval. And the curves look really pretty similar. The progression-free survival is about 18 months on the left and 12 months on the right. So a little bit worse. But it's very dependent on depth of remission. So complete remission turns out to be the best predictor of outcome with the CAR T therapy. The partial responders end up with an outcome a little bit better than the overall cohort, but not that much. And this is somewhat unusual because what we've seen with most studies recently is that undetectable MRD is a stronger predictor than response. But if you look at the curves on the bottom, that's progression-free survival by rates of undetectable MRD. And undetectable MRD is not as good a predictor in this setting. This is probably because the partial responders, some of them did have undetectable MRD in blood or bone marrow, but still had lymph node disease, which was a predictor of worse outcome. So CR is more predictive than undetectable MRD, and that's only about 20%. So if you think about this patient population where Lysocell and pirtobrutinib are approved, it's likely that the ease of use of pirtobrutinib, as well as the PFS that's similar or better, would likely lead you to use pirtobrutinib before CAR T in most patients, except perhaps maybe some very young fit ones who are hoping for a more definitive therapy. The double refractory population does have a worse outcome than the full population, similar to what we saw with pirtobrutinib. But again, a little bit hard to interpret whether that's specific to the drugs type that the patients have received or just what we've seen always, that the more prior therapies, the harder it is to get disease response. And we also heard a presentation at EHA last year that patients with 3 or fewer prior regimens and who did not have bulky disease were more likely to achieve a response. And so even though this is an immune therapy, similar to all our other treatments, it's better to have less disease when you get it to get a deep response. And then we heard at ASH an update on the Lysocell with ibrutinib cohort, also a heavily pretreated population. But the data here look a little bit better. The complete remission rate is 45% and the overall response rate 86%. And undetectable MRD is reaching 85 to 95%. So that looks quite good. And on the right, we can see that for all patients, the PFS is about 31 months compared to about 18 months with the other regimen. So again, not a head-to-head trial, parallel cohorts, but perhaps a suggestion that the addition of ibrutinib may be helping the outcomes with Lysocell. And of course, we believe that this may be due to normalization of the T cells in the period before CAR T and normalization of the immune system to also be able to respond to the T cells. So again, heavily pretreated cohort, CR rate, it looks higher than Lysocell alone, but it's hard to compare patient populations across studies. There are the issues of ibrutinib side effects. There's a brain hemorrhage on this trial. In 2 prior studies that combined ibrutinib with CAR T, there were 2 cardiac arrests during the period of cytokine release syndrome. And still 59% of patients with the ibrutinib needed steroids or TOCI for CRS. So personally, I think it would be of interest to study second generation BTK inhibitors or beyond in the context of CAR T to hopefully reduce some of these ibrutinib side effects, particularly the cardiac ones. The data from ex vivo experiments, mouse experiments, suggest that the second generation BTK inhibitors can also normalize T cell function, which suggests that it's not due to the kinase inhibition profile of the drug as much as it is due to the inhibition of disease and disease reduction that we see. And then epcoritamab is the bispecific antibody that's been best studied in CLL, where we've heard data before. And at ASH this year, we heard about the cycle 1 optimization cohort. So in the prior expansion cohort, the CRS prophylaxis was only prednisone with 2 step-up doses before the first full dose. So in this optimization cohort, they used dexamethasone prophylaxis with hydration and added an extra step-up dose before the first full dose. And this is because the rate of CRS was really still pretty high in the expansion cohort. You can see on the right at the top, CRS incidence is highest and worst at the first full dose, and there were still 18% of grade 3 events with the epcoritamab in the expansion cohort. But with the additional step-up dose and prophylaxis shown at the bottom, there were no grade 3 events. There were overall lower rates, and most of it was grade 1. So I think they did make some significant progress here in terms of improving the toxicity to make this a more usable therapy. And CRS is still most common at the first full dose, but there's no grade 3 and mostly grade 1. And in these heavily pretreated patients, the overall response rate was 61%, regardless of high-risk features such as unmutated IGVH or 17p deletion. And the complete remission rate of 39% was particularly encouraging, as well as undetectable MRD in 75% of responders. And the median progression-free survival looks to be about a year from this cohort. So this study is continuing to accrue, and I think it'll be of interest to design combinations or consolidation strategies for patients who still have detectable MRD in earlier lines of therapy. And finally, I'd like to conclude with 2 novel BTK degraders. And so these are molecules that bind to BTK and hook them up with the ubiquitin ligase, and so target BTK for degradation. And there are 2 of particular interest in the clinic, which we heard about at both EHA and ASH, and these are the data from ASH. And X5948 is shown here. And on the left, you can see how heavily pretreated most of these patients are. They pretty much all of them had chemoimmunotherapy, covalent BTK, and BCL2 inhibitor, and several have had non-covalent BTK inhibitor as well. The overall response rate has been 76% across all dose levels. This is just in the CLL patients, although there's also ongoing work in non-Hodgkin's lymphoma. The median duration of treatment is still very short at only 4 months, but you can see from the green arrows on the graph that most patients are still on therapy. So this looks quite encouraging. And then the other drug is BGB-16673. Again, on the left, all the patients have had covalent BTK and BCL2 inhibitor, and a smattering have also had non-covalent BTK. The overall response rate is almost exactly the same at 78% across all dose levels, which I think is really remarkable and suggests that we are seeing real activity of this class of drugs that's potentially very promising. And the follow-up here is 11 months, but still many patients are still on drug, as shown by the arrows on the plot. So we have 2 phase 1 studies of distinct molecules in heavily pretreated patients, most of whom have had prior BTK and BCL2 inhibitor exposure. And both studies are showing a very nice overall response rate of approximately 76%. Follow-up is short, but very encouraging. And mechanisms of resistance are still to emerge, but will be very important. You know, right now, I think we have a sequence of patients going from covalent BTK inhibitor to non-covalent BTK inhibitor to BTK degrader. And we see different patterns of BTK mutations with the covalent and the non-covalent. And we don't know yet what types of mutations may confer resistance to BTK degraders, but there likely will be some because the drugs do have to bind to BTK. And so that may affect the sequencing of the drugs over time. And if the BTK degraders are less likely to develop resistance, then that may move them to an earlier line of therapy. So very exciting times for our CLL patients now. And thank you for your attention.